Hi everyone, my name is Carina Carino, and in this video, I will discuss my research project, which is using radiomic features for NSCLC risk stratification and prognosis. The American Cancer Society estimates that this year alone in the US, there will be 236,000 new cases and 130,000 deaths from lung cancer. Lung cancer is also by far the leading cause of cancer, making up almost 25% of all cancer-related deaths. About 80 to 85% of lung cancer are NSCLC, or non-small cell lung cancer. And just a quick review on imaging modality. CT scans or computed tomography basically shows the detailed non-moving image of organs, bones, and tissues, while PET scan can find abnormal activities. And in this case, for the study, it's tumor around the lungs. And PET scans are also more sensitive than other imaging tests since it uses radioactive tracers which collect in areas of higher chemical activity. Both PET and CT scans can be performed at the same time. It can help, again, pinpoint the abnormal metabolic activity, as well as help clinicians diagnose accurately. You can use PET scan to find how big the cancer is or whether it has spread in other parts of your body. So you can tell which stage of cancer you're in, and which can then decide the best treatment for your cancer. So first, I want to discuss the importance of these studies. We know that patients diagnosed with NSCLC confront several decisions related to management of their disease. Opting for treatment or relief of symptom is an extremely critical decision that should be made right after diagnosis. Treatment options depend on where and how far the cancer has spread and the patient's overall health. So if you're treating a early stage and person who is in relatively good health, that person might opt for surgery or chemotherapy. Otherwise, opting for treatments that will relieve symptoms is the best course of action, even though these treatments aren't likely to cure the patients. It's more for relieving the symptoms. So these decisions are critical. Therefore, informed decisions related to the management of terminal illness requires accurate prognosis. So this is where we come in. So a fundamental hypothesis for this study is that we can use machine learning algorithms and techniques to integrate medical images in order to stratify, basically group NSCLC patients and predict their overall survival, which can then guide clinicians when dealing with treatment strategies. Okay, for the methods. This flowchart illustrates the approach I followed. So NSCLC tumor was first segmented using ITK SNAP from the medical images, yielding high-dimensional radiomic features for each patient. Then UMAP was used to reduce the dimensionality of the radiomic dataset as well as visualize the original dataset. Then lastly, we performed survival analysis using Cox proportional hazard and Kaplan-Meier's curve for survival prediction and visualization. For the dataset and image pre-processing, so PET and CT images and clinical characteristics from 160 NSCLC patients were collected for these studies, but we only used 130 of those. So the clinical data set provided the patient's age, gender, smoking status, time of the last follow-up, and their survival status. So whether they are alive or dead. And again, PET-CT images were manually segmented using ITK SNAP version 3.0 and a dataset with 431 radiomic features were then extracted from the segmented images. So for dimension reduction, first we used the elbow method to determine how many features we need. So the optimal number of features we want. And then we used UMAP to reduce the dimensionality of the radiomic dataset. So again, remember, we have around 130 patients and 431 features. So we need to reduce that to a lower dimensionality, lower dimensional space. I won't discuss the theory behind UMAP, but the reason I chose it is because of its superior runtime compared to other dimension reduction techniques such as Disney, as you can see in the images below. PCA is still the fastest option, but you are potentially giving up a lot for that speed. While UMAP is not competitive with PCA, it is clearly the next best options in terms of performance. Given the quality of result that UMAP can provide, I feel that it is a good option for this study. For survival analysis, we first perform risk stratification, basically assign each patient as either high risk or low risk. We also used Cox proportional hazard to investigate the relationship between time to event outcome and a set of variables. So in this case, in the study, set of variable meaning the clinical features as well as the low dimensional features. Again, we also use Kaplan-Meier curve for visual representation of the patient's survival. For the results, so a total of 126 patients were investigated since 4 were excluded, of whom 74% were male, and the mean plus or minus standard deviation age of the patients was around 68 or 69 years of age. In addition, 66% of the patients were former smokers and 19% were current smokers and 15% never smoked. The median follow-up time was 682 days of all the patients. 65% of all the deaths occur during this period. So 65% of all the deaths occurred before the median follow-up time. So we were able to use UMAP to visualize the overall global structure of the data as well as its connectivity, as you can see in the left image. And so using the elbow method, we determined that we needed around 5 features, UMAP features for this data set. The image on the right is basically box plot of the UMAP features. It's just to show that each features are independent of one another. You can see the interquartile range of the features and the whiskers as well show minimal spread. meaning the data is less scattered and there aren't any potential outliers, while the data appear to be symmetric for all 5 UMAP features. Categorizing the patients between high risk and low risk proved to be significant since we got a p-value of 0.019, which is lower than 0.05. So we categorized 63 of the patients as low risk and 63 of the patient as high risk. We also assessed the fitted survival model just to make sure that it follows the proportional hazard assumption, as you can see on table 2 under pH test, so proportional hazard test. All covariates received a p-value greater than 0.05. Therefore, assumptions were satisfied and the Cox pH model is suitable for this study. So we also found that age is the most significant, most statistically significant among the 8 covariates, having a p-value of 0.007. But although age is significant to the model, its hazard ratio is only 1.04, meaning older patients are 4% more likely to suffer risk than patients that are younger. We also found that smoking status and UMAP3 features obtained p-values of around 0.08, bordering on statistically significant. The hazard ratio for smoking status is 1.35, meaning patients who currently smoke or have smoked in the past are 35% more likely to die from non-small cell lung cancer than non-smokers. We also found that gender and the rest of the UMAP features did not have significant association with NSCLC survival, since their p-values are greater than 0.05. All right, so on the left, the survival probability curve for both gender, you can see are similar for both male and female, as well as p-value of 0.72, which is greater than 0.05. However, note that, again, 74% of the patients were male. On the left, it can be seen that patients older than 68 years old are at higher risk than patients that are under 68 years old. And it has a p-value of 0.037, which is significant. So for discussion, we were able to first integrate medical images of the patients by using machine learning algorithms and techniques such as segmentation, dimensionality reduction using UMAP feature extraction. Also found that stratifying patients into high risk and low risk group proved to be significant, and that age was the only reliable survival factor out of the 8 covariates. And lastly, analyzing the prognostic performance of each UMAP feature is futile since the original radiomic features were transformed. So even if we know that, say, even if they're significant, we really wouldn't know what that feature is since it's already transformed. If you want to know what which radiomic feature is reliable for survival factor, then you have to use a feature selection method. So it doesn't transform the feature, it just selects like a subset of it. And so therefore, this approach was not designed to identify survival markers. So in conclusion, this study highlights the importance of integrating the patient's clinical data, demographics, and other variables such as medical images to accurately predict overall survival, which may offer insights for clinical physicians regarding treatment strategies. For future work, to improve our model, we can split the data into training and testing sets, and then train the model and validate the results so we can have a more robust predictive model. And that concludes my presentation. I have my resources here. Thank you so much.